growth with the orthodontic treatment. So today we're going to talk about the growth and developments of the maxilla and mandible. So we'll go through maxilla first, then later followed by mandible. So the learning outcome at the end of lecture, you should be able to outline the method of the bone growth and explain the prenatal and postnatal of the maxilla and mandible growth. So mechanism of growth in the hard tissue. So we know bone is specialized tissue for the mesodermal origins of the mesodermal origin. It means all the bone is from the mesoderm. Then they form the structural framework of the body. Without the bone, there's no muscle, then the soft tissue can attach to it. So the bone actually is a structural framework of the body. Then it also a calcified tissue that support the body and give the point of the attachment of all the muscle. And the normal bone actually contains about 32 to 36% of organic matter. So the rest are calcified tissue. So osteogenesis, it means the process of bone formation. It's called osteogenesis. Then formation takes place into two ways. There are two methods of the bone formation. So the first one is endochondral bone formation. The other one is intramembranous. So for this maxilla and mandible, they are a bit of both. So maxilla mainly is intramembranous, but the mandible, they contain endochondral and intermembranous also. So first we will talk about intramembranous bone formation. So it's from the undifferentiated mesenchymal cells differentiate into the osteoblast. Then this osteoblast will secrete the osteomatrix. This matrix will become calcified further. Then they become a bone. So these mesenchymal cells then form the osteoblast. Osteoblast forms the matrix. Then the matrix calcified to become the bone. That's intramembranous. Intramembranous. These intramembranous bone formations occur in the area exposed tension. When there's a tension, then it's formed these intramembranous bone formations. So formation of the bone is directly from these mesenchymal cells or tissue. You see in the area like cranial valve, the skull, and then maxilla and mandible, except condylar cartilage. So mandible, they are a bit of both, intramembranous and endochondral. But mainly, the whole skull, included the maxilla and mandible, is by intramembranous bone formations. So this picture is just summarize the intramembranous formation. First, we have these mesenchymal cells. Then slowly, they form the osteoblast. Osteoblast will secrete the osteo. Then osteo will slowly become calcified and become bone. So they form the bone matrix. Then slowly, this blood vessel will infiltrate. Then they form the trabecula, which is some space between the cell. Then this one will form finally the mature bone, eventually. So endochondral is a bit different from intramembranous. They usually have what we call the cartilage, the involvement. So the cartilage cell undergo hypertrophy. Then the matrix become calcified. Then this cartilage become degenerated. They disappear. So they form the matrix that becomes calcified. Then later the cartilage itself will become disappear. So the cell degenerate. Then this osteogenic, like osteoblast, will secrete or come in way the integrating cartilage and replace it by the formation of bone. So cartilage will come first, they become bone later, then this cartilage will disappear. So endochondral bone formations occur in the region exposed to high level compression. So first time we talk about intramembranous, it's more to tension. Then this endochondral is more to compressions, high level of compressions. In the craniofacial regions, it is seen in the area like synchondrosis at the cranial base. Synchondrosis means there are two joints between the cartilage, it called synchondrosis. Then the cartilage is condylar cartilage also, this is septal cartilage, those areas. So you see this bone is formed by the endochondral. First we have the cartilage. Cartilage is a white color cartilage. Then slowly we have this primary ossification center. Then slowly the bone will come in. Then this bone will invade. Then the cartilage will disappear. But sometimes the cartilage will left at the end, like condyle or the long bone. This one will left behind. So the cartilage sometimes will completely degenerate. Then sometimes they're left behind a little bit, which is cover the end. So how the bone will grow bigger or become larger or longer? They usually by remodeling, displacement, or a big combination of both, remodeling and displacement. So remodeling means a process involves depositions and resorption occurring on the opposite end. So you look at the right pictures. So a negative sign, it means represent this resorption. Then positive sign is a deposition. So it must be 1 plus, 1 minus, must be balanced. Then the bone can move forward and become bigger. So progressively changing the size of the whole bone, sequentially relocate each component of the whole bone. Because the bone is joined together, like your maxilla is joined to the base of the skull, and then your mandible is joined to the maxilla. When they grow, then they will affect each other. So this one is just a typical example. It shows how the maxilla grows. Let's say maxilla want to grow forward. There must be some depositions and resorption occur. Then the bone will reshape and then move in the forward direction. Displacement. So refer to the shift in position of the bone. The bone will move downward and forward generally. Maxilla and mandible also move downward and forward. So there are two types of displacement. So the first one is primary, then the second type is secondary displacement. So the difference between them. So primary displacement, it just means it's physical movement of the whole bone that occur while the bone grows and remodeled by the resorption and deposition. So the bone itself, they have a plus and minus, which is resorption and depositions. When this happens, then the bone will grow or they will move. That's called primary displacement. By its own, the bone grows itself by deposition and resorption. That's why it moves. Secondary displacement is a movement by the whole bone caused by separations or separate enlargement of other bone. Because the other bone grows bigger, that's why it push the other bone to the side or to the front or the back. This is called secondary displacement caused by other bone. So look at these pictures. On the left side, this is a primary because the bone grows itself, have a plus and minus. And on the right side, this one is secondary. You see when the maxilla grows, we push it away from the base of the skull. This is called secondary displacement. So primary by itself, secondary pushed by others. So this one is just summary. Primary displacement means the movement of bone as the bone enlarges itself. It's called primary displacement. And the movement can be either in the direction of bone depositions or direction of bone resorption. So what it means, it can be, okay, go back to these directions. So this one is a plus, this one is a minus sign. So the bone can grow or move in the positive directions or the negative directions. So it can be either direction. So as the bone enlarge, it's carried away from other bone. Growth remodeling takes place to maintain the contact. The condyle will grow upward and backward to maintain the contact with the fossa, and the mandible is placed downward. What I'm trying to say, when the bone is grow, they still join together. It's just joined together. So the bone cannot be separate. When you grow, then they must be joined together. The space in between must be filled up with new bone. It's how the bone grows. Similarly, then the maxilla is displaced downward and forward to maintain the contact. Bone deposition takes place in the upward and backward direction. So this one is just an example of the primary displacement. You see, when the mandible grows downward and forward, then the condyle will grow backward and upward. So maintain the contact with the base of the skull. So movement of the whole bone is caused by the enlargement of the other bone. This is secondary displacement. Movement of the whole bone is caused by the enlargement of other bone, which is present, nearby, or quite distant, is called secondary displacement. So due to other bone is growing bigger, that's why they push the other bone to the other side. This is called secondary displacement. So increase in size of the middle cranial fossa cause the maxilla to be displaced anteriorly and inferiorly. Okay, this is independent of the growth and enlargement of the maxilla itself. So what I'm trying to say, whether if the bone is growing or not, if other bone is growing, then you will push this bone to other side. So for example, let's say this mandible, they are not growing, it's maintained the same size, but if the base of skull is growing, going to push the mandible forward also. That's called secondary displacement. Combination of remodeling and displacement, both of these mechanisms operate together. So they're not separated from each other. It's always happen together. Remodeling and displacement happening together. So though plus minus is called remodeling, and displacement is moving forward, downward, upward, and backward. That's called displacement. Both happen together. Both of these mechanisms operate together and cause an enlargement and movement of the bone. So you see this maxilla moving downward and forward, displacement, and also this remodeling, which is a deposition and the resorption happen at the same time. Okay, now we come to the maxilla first. So maxilla. So prenatal means just before the bone. Prenatal growth of the maxilla, still inside the baby, still inside the mother uterus. That's called prenatal, before bone. So at the 4th week of the intrauterine life, so IUL, short form. So it's still inside the mother uterus. And this one at the 4th week, then the shallow depressions. So this one will form the primitive mouth. We call it stomatum. Stomatum is somewhere around here. You see on the right picture, the black color in the middle, this one I call it primitive mouth, which is a stomatum. So the floor of the stomatum is formed by the buccal-pharyngeal membranes, so which is the first arch. So you see this stomatum is surrounded by so many structures. Look at the right pictures here. So these some black colors or black shadow in the middle. Surrounding it is so many structures involved. So the first one is the frontal nasal from top. Frontal nasal. Then the nose is have the medial nasal, lateral nasal. Then on the left and right we have the maxillary process. Then on the bound side we have the mandibular process. Look at this picture. So this blue color is a middle and lateral nasal, and this one light blue color is a frontal nasal. Then this one, the red color, is a maxilla. Then the green color is mandible. So all will come together and form the mouth and the nose. Okay, so this one is a microscopic pictures. So it shows that the frontal nasal on the top, then stomatum, which is the black triangle in the middle. Then we have a medial nasal, then lateral nasal, that form the nose. Then we have maxillary process on the left and right, which will come together later. Then we have mandible process at the bottom. So again, these are microscopic pictures. Just repeat what we said just now. Frontal nasal from the top, we have the nasal pit, and in the medial side, we have the medial nasal prominent or the process. Then distal, we have the lateral. Then we have the maxilla left and right. And then bottom, we have the mandible. In the middle, there's always the primitive mouth, which is stomatum, in the middle. So prenatal empyrology. So we know the face divided into 3 parts. We have upper, then middle, and lower. So the upper is formed by this frontal nasal. Then middle, we have this maxillary process. Then lower third is a mandibular process. So the ratio for these 3 parts should be 1:1. Upper, middle, lower must be in proportion in order to become beautiful and handsome. So this one is just summary of just how we say. Frontal nasal on top. Then we have the nose left and right, then formed by the medial. Then this one is the lateral. Then we have the left and right maxilla, and then the bottom is the mandible. So again, this one is a summary. Summary of what. Slowly you become an adult. Then when you're born, then you become adult. Then this one should form the upper, middle, and the lower face. The upper nasal process. Then the middle is by maxillary process, and then the lower is by mandibular process. So all these must be in proportion 1:1 in order to generate a beautiful face. So prenatal growth of maxilla. So at the 7th week of its intrauterine life, or IUL, then the formation of upper lip was started. Then intramembranous ossification took place. Then formation of nasal septum, nasolacrimal duct, then formations of the primary palate. All these happen in 7 weeks. Then at the 8 weeks, then 2 intermaxillary ossification centers then generate the alveolar bridge of the primary palate. This time we will talk about it with the picture easy. Then intramembranous ossification center appear for the nasal lacrimal bone, medial pterygoid plate or sphenoid, warmer, and then zygomatic bone. We use the picture to explain this. So on 28 days, which is the 4th week, then in this integration of the buccopharyngeal membrane, which is the first pharyngeal arch, then they'll form this oral cavity and a nasal cavity. So stomatal chamber. Okay, so divide the oral cavity and nasal cavity on the 4th week. Then palate formations is a horizontal extension. We have 2 secondary palate shell, then we have single primary palate. All these 2 parts have to join together to form the palate. I have primary palate and we have a secondary palate also. So there are 3 stages: formation of primary and secondary palate, and the elevation of palatal shell, and then they join together, which is a fusion of palatal shell. So first the formation, then later the elevation of the palatal shell, then after that they will join together. Again, this one we use a picture to explain better. So you see, this one is a frontal nasal process. We have the nose, this one maxilla, mandible. So the primary palate, which is the red color, this one called primary palate or premaxilla. So this one is all formed by the mesenchyme cell, then later it become wedge-shaped mass between the internal surface of maxillary prominence. That become primary palate, which is formed the premaxilla. So this red color, they'll form the premaxilla, which is a primary palate. Then later we have secondary palate, which is at the back, or by this yellow color in the pictures, yellow color, this is secondary palate. All these 3 parts have to join together to form the palate. So we have 2 horizontal mesenchymal projection. This one will form the secondary palate. It's a lateral palatine process. Then they will fuse together. Then they form a secondary palate. So these red colors, secondary palate, they have to come together, left and right. Then this must be joined in the middle. If this doesn't happen, they'll form the cleft palate. So anything disturb the procedure of fusion between the primary and secondary palate will cause a cleft. So if you look at the right pictures, from top and from the side, all have to join together. So this one is also connected with the nasal septum also. So it has to be each other, the primary palate and nasal septum all have to join together. So at the 6th week, again IUL, the tongue will push downward, then the palatal shell will become vertical, elevate, it will go up, and then it will join together. Elevation occurs from the horizontal to vertical position. So slowly the tongue, you see this one is blue color is the tongue, and this one will push downward. MC is a macrocartilage, which is a mandible. We'll talk about it later. So the tongue will push downward. When the tongue pushes downward, then this palatal shell will lift upward. And then they'll come together from left and right. Then finally, we'll join together, of course, not only to the secondary palate, also to the nasal septum on top. When this join together, then the palate is considered fully formed. The tongue will press downward. So if anything disturbs this procedure or the fusion, then we will form the cleft. So again, this one is summary. Movement of the palatal shell and the tongue during the palate closure. The tongue moves anteriorly, depressing downward, and laterally as the palatal shell slide from B to A over the tongue. Same thing, the tongue have to go downward, then the shell will go upward, then they come to each other, and then they fuse in the middle. So again, this one is a microscopic pictures, which show that the palatal shell will elevate. This one is a secondary palate, and they come together. Then with the primary palate, all will join together to form the hard palate. So what is the clinical significance? So this fusion or this elevation of secondary palate is very important. Like I said before, if something happened during this procedure or these fusions, then cleft will happen. So cleft palate is a failure of fusions of lateral palatine process with each other or with the median palatine process. So the fusion must be primary and secondary. So you have two secondary, left and right, primary, middle, front. So all these parts have to join together to form the full palate. So either part is not joining, then we have the cleft. Sometimes they're not joining on the left, and sometimes they're not joining on the right. Then we have the right or left palatal cleft. So the primary palate formation is about 4 to 5 weeks, and the secondary palate is about 6 to 7 weeks. So that's a typical example. You see these clinical pictures to show that it's a cleft palate happening. So this one is a failure of joint between the secondary palates in the middle. So this is quite a big cleft. So you imagine this, if you have a cleft happen, then the water and food can go into the nose because there's no separation between the oral cavity and the nasal cavity. So not only the food will go in, you have difficulty in pronounce certain words. So when you look at the cleft baby or child, then we can differentiate to the lips and palate. All this is not fused or not joined together, then it causes the cleft. It can be from the nose up to the lips and then up to the palate. Sometimes single side, left or right. Sometimes it can be both sides. Sometimes it only happens in the middle. Depends which part is failed to fuse or failed to join together. So we say before, at the front we have a primary, and then at the back we have secondary palate. Then of course on top we have the nose or the nasal septum. All these have to join together to form a completely beautiful nose and the lips and the palate. So either of the processes of the shell is not joined together, then we form the cleft. So it can be the nose, then it can up to the lips. It can be a single side, or it can be both sides, or it can be just in the mid-palatal side. So we finish. Developed postnatally entirely by the intramembranous ossification. You see the maxilla, the growth is only intramembranous. The mandible, a bit of both, but mainly again is intramembranous, a bit of endochondral. But maxilla purely by intramembranous. So you get these questions a lot of time during an exam. They will ask you the maxilla is it grow by intramembranous or endochondral. Then well, whereas the mandible is by both intramembranous plus endochondral. So since there's no cartilage replacement, the growth occurs by 3 ways. We talk about this, displacement. Then first is displacement. Second is the growth at the suture. Again, this one is a bit of displacement also. Then surface remodeling. So you just repeat what we discussed just now. It's by the displacement and remodeling. So the growth pattern of maxilla requires that it grow out from the cranium. It must be grow forward and downward, which is growing out from the cranium. Then, which means the maxilla must move downward and forward, downward and forward. Then we move downward and forward. That's how the face will become longer and more bigger or wider. So the suture attached the maxilla posteriorly and superiorly are ideally situated to allow its downward and forward repositioning. So you see the maxilla attached to the base of the skull by the sutures. When all these sutures enlarge or we have remodeling, then that's how the maxilla will grow away from the base of the skull. So the sutures are all oblique and more or less parallel to each other. This allows the downward and forward repositioning of the maxilla and to grow occur at this suture. So when this suture, we have more bone deposit or resorb than deposition, then they will push these two bones away from each other. That's how we get the growth, remodeling and displacement. So you see the skull and the maxilla, we have so many sutures. Suture, it just means the joint between these two bones. We have so many different bones on the skull. The joint is called suture. So the maxilla is connected by the cranium or cranial base by a number of sutures. So for example, For the frontal bone to the nasal bone, you call it frontal nasal suture. Then frontal bone to maxillary bone, you call it frontal maxillary suture, which is here, number 6. Then zygomatic, temporal suture, so many suture. Then from the side also, we look at it, we have so many suture, frontal zygomatic suture. Some suture will grow, then the bone will displace upward and downward. For example, this frontal zygomatic suture, which is horizontal. So when this have a deposition or resorption, or the bone will displace in the vertical manner. So if you have this frontal maxillary suture and the nasal maxillary suture, then the bone will push in the horizontal manner. Then some will go to lateral manner, zygomatical maxillary suture. This one will push the bone in a in the lateral manner. That's how the skull will grow in the 3 dimensions. So some will grow vertical, some will go horizontal, AP, anterior posterior manner. Some will go lateral, mesial distal. So again, this one, the picture is a side profile. We just show you so many suture. When this suture have a deposition, then that's how the bone will push away from each other. That's how the skull will become bigger, and the maxilla push downward and forward. Same with the mandible, downward and forward. So as the downward and forward movement occur, the space that would otherwise open up at the suture is filled by the porifications of the bone at this location. So you see the bone is joined together. So even though if your maxilla and mandible move downward and forward, they must be still attached to the skull. So this separation must be filled up by the new bone. Otherwise, the whole maxilla and mandible will detach from the skull. So maxilla is attached to the cranial base by suture. So therefore, the growth at the cranial base and the growth at the maxilla. So just like we discussed before. So if the bone grows bigger, they will push the bone next to it to a further place. This is called secondary displacement. Same with this picture. You see this on the base of skull. If the skull grows bigger, they will push the maxilla and mandible downward and forward. That's called secondary displacement. Again, maxilla and mandible must be attached to the skull or the base of the skull, and this one must be filled by the new bone when they move downward and forward. So the suture remain the same width. And the various processes of the maxilla become longer, and the bone apposition occur at both sides of suture. So the bone of which the maxilla is attached also become larger. Just like we said before, this suture must attach all the bone together. So when the bone grow, it must be bring the other bone grow in the same direction also. Or sometimes you push each other away from the suture. That's also called displacement, primary or secondary. So elongation of synchondrosis, we also discussed this before. The synchondrosis is just mean the joint between two cartilage. So most of the bone at the cranial base are formed by the cartilageous process. Then later the cartilage is replaced by the bone. The remain cartilage at the junction of the various bone are called synchondrosis. So you see the base of the skull, there's so many parts of the bone, then all joined together by this synchondrosis. So these are important growth sites at the cranial base. They are the primary cartilage. It's important synchondrosis found at the cranial base are these 4. So the joint between these 2 bones, then there's synchondrosis. We have a sphenoid occipital, which is joint between the sphenoid bone and occipital bone. So this one is a sphenoid. Let's see where's the sphenoid occipital. Okay, here. So this one is a sphenoid bone. It's an occipital bone. So the junction, you call it sphenoid occipital synchondrosis. Then same, likewise for the other bone also. So the joint become the names of 2 bones. Intersphenoid means it's the sphenoid bone itself. They also have synchondrosis. So this one you see intersphenoidal. It just means between the sphenoid bone, there's also one joint. So intra occipital. So this is an occipital bone. There's also one joint within the bone itself. So part of the posterior border of the maxilla is a free surface in the tuberosity region. So you see the posterior border of this maxilla, which is a free surface or tuberosity region. So bone is added at this surface, creating additional space into which the primary and then the permanent molar teeth successfully erupt. So you see this back area is called tuberosity. This tuberosity must be grow a bit bigger or longer to accommodate more teeth to come out. You see the baby or the young child, they have a shorter maxilla, but this maxilla only accommodate all the baby teeth. Eventually, this maxilla must grow a bit bigger and longer, especially as the back surface, which is the tuberosity, to accommodate more permanent teeth to come out. So the whole of the maxilla undergoes simultaneous process of primary displacement of the anterior and inferior direction as it grows and lengthens posteriorly. So we talked about this before. The maxilla will grow downward and forward direction while they're separated or they're pushed away from the base of the skull. So this one is joined by the suture. When the suture grows, then this maxilla and the base of the skull also will grow. Again, this one, you call it primary displacement and secondary displacement. All happen at the same time. So as the maxilla grows downward and forward, its front surface are remodeled and the bone is removed from the most anterior surface. So we know remodeling, it just means a plus and minus sign, which is a deposition and resorption of the bone. So you see, this picture we showed before, the maxilla is like a platform on wheel. It's being rolled forward, then while at the same time its surface represented by the wall is being reduced on the anterior surface, then build out the posterior surface, and moving in the space opposite on the direction of overgrowth. So you see this picture, when the maxilla grows downward and forward, there's some deposition and resorption occur. Otherwise, the whole face will move forward, which is not what we want. Usually, the maxilla, only the alveolar process will grow a bit more than the maxilla. So the maxilla must be remodeled when they grow downward and forward direction. So surface remodeling, again, is a plus and minus sign we show in the picture just now, which means the deposition and resorption. In addition to the growth at the suture, massive remodeling by the bone deposition and resorption occur to bring about the increase in size. Change in the shape of the bone can happen, or change in the functional relationship. So for example, your maxilla and mandible, they're attached to each other by the base of skull. So let's say if the maxilla grow more, then you become class 2 skeletal. If the mandible grow more, then you become a class 3 skeletal. So sometimes this surface remodeling also will bring the change in the functional relationship. So surface remodeling in the nasomaxillary complex, the nose, the eye, and the palate. Resorption occur on the lateral surface of orbital rim. So you see the lateral surface of orbital rim, we have a resorption leading to lateral movement of the eyeball. So the eyeball will go a bit wider with time because of the resorption of the lateral surface. To compensate this, there's a bone deposition on the medial rim of the orbit and the external surface of lateral rim. I see this one must be a plus and minus must be in balance. So when the eyeball grow a bit bigger and it go a bit wider, then this one must be depositions and resorption happen at the same time. That's how the face will grow bigger at the sideway. So surface deposition occur in the superior, lateral, and anterior direction, resulting in growth. So the bone resorption is seen on the floor of the nasal cavity. So the floor of the nasal cavity also is the base of the palate, the base of the palate. So to compensate, there's a bone deposition on the palatal side. So the bone resorptions on the floor of the nasal cavity, then deposition on the palate. That's how the maxilla will grow downward. And if you remember what I mentioned in the last lecture, it's a V. It's like a V, a big V, enlarging V. So this V will go downward. So imagine this one is the first V, then slowly we move the bigger V, then finally the last one. So this must happen with the depositions on the palate and then resorption at the floor of the, or the base of the nasal cavity. So this result in the downward shift and increase in maxillary height. So downward and bigger V, again, summarized in these pictures. So the palate is like a U shape or V shape. This V shape must become a bigger V, so in order the maxilla to grow bigger. And then how this happens? It's by the remodeling, which is caused by the resorption on the base or the floor of the nasal cavity, and then deposition on the palatal side. So the zygomatic bone moves in the posterior direction by resorption on the anterior surface and deposition on the posterior surface. Again, it's a plus minus sign. So we have a resorption on the anterior surface, this anterior surface. Then we have a deposition of the posterior surface. Again, have a margin sign, must have the plus sign, must be in the balance. Then the face also enlarged in width by bone formation on the lateral surface of zygomatic arch and resorption on the medial surface. So you see, this one, you see the side, we have the deposition on the lateral surface of zygomatic arch, and then we also have the resorption on the opposite side, which is the medial surface. So the anterior nasal spine, which is here. So it increased due to the bone deposition, which is on the A. So this A, which is nasal spine. So the nose will go forward a little bit. Then in addition, there's a resorption from the periosteum surface on the labial cortex. You see this labial cortex, which is B. This one become resorption. That's why you become more prominent. The face will become more prominent. The nose will go forward, while this one, the labial surface of the cortex will become resorption. We form this curve, So bone deposition occurs on the endosteal surface of the labial cortex, which is C. Then the periosteal surface of lingual cortex, which is D. So when there's a plus, must be minus, and this one plus will be minus. So they maintain the same thickness of the bone, then the bone still can change in the shape. That's how it happens. Some minus, some plus, some minus plus. But if you have one plus, then the opposite side must be a minus. So we can maintain the same thickness of the bone. So as the teeth start erupting but when the teeth start erupting, the bone depositions occur at the alveolar margins, which increase the maxillary height and the depth of the palate. So when the teeth start erupting, we have a vertical increase in the alveolar height, which is bone also. Then we also have the palate become deeper, because the alveolar process will grow longer, then the palate will go deeper. So you notice the baby, you should have a shallow palate. Then when you become adult, you should have a deeper palate, because the teeth become longer, alveolar process will become longer. So the entire wall of the sinus, except the mesial wall, undergo resorption, which result in the increased size of the maxillary antrum. So the antrum or the sinus all will become bigger, except the mesial wall. Where's the mesial wall? Mesial wall is next to the nose. So the nose cannot become smaller. That's why except the mesial wall, everything will go sideways. They will expand. That's why it will go bigger and wider. So maxillary antrum or sinus will grow bigger. Okay, I think now we finished the maxilla. So any problem, any question for the maxilla? Before we proceed to mandible, any questions?
No, doctor.
Okay. So mandible is a bit more complicated. Because we have two types of bone formations. One is the endochondral, then the other one intramembranous. So prenatal again, inside the mother uterus, then we have the first pharyngeal arch, which is a mandibular arch, which contains the macrocartilage. So you see this one, the red colors on the right pictures. This one red color is called macrocartilage. So these appear on the 6th week of the IUL. 6th week. So what is this macrocartilage is so important? In fact, it only makes a little contribution toward the development of the mandible, but this macrocartilage provides a template or the scaffolding for the subsequent development of mandible. It doesn't contribute much to formation, but they have a base or the scaffolding or the template for the formations of the mandible. So around 6 to 7 weeks, about 4 to 5 weeks, about 4 to 5 weeks on the IUL. Then there's an ectomesenchymal mesenchymal condensations lateral to the metacartilage, not inside the metacartilage, it's lateral to the cartilage. That's why we say the metacartilage, they are not endochondral formation. It's still the intramembranous, because this metacartilage is only the template. It doesn't contribute to the formations, only the template. So some mesenchymal cell will enlarge, and they form the osteoblast. Again, this osteoblast will secrete the osteo, then the osteo will become calcified and become the bone. So I want you to be very clear, this metacartilage, although it contributes a little bit, which is formed as a template, but the whole formation of the bone is still considered intramembranous. It's not endochondral. Although we have a metacartilage involved, but indirectly. So the resulting of intramembranous line lateral to metacartilage. You see this red color is a metacartilage. So you see the bone formations. This white color is metacartilage. So the red color is the new bone formations. So you see the bone formation is lateral or on top of this metacartilage, but it's not within the cartilage. It's not inside the cartilage. It's only forming at the side of the cartilage. You use this metacartilage as a template, then it forms the bone on top. So it's still considered intramembranous, not endochondral. So in the 6th week of the IUL, single ossification center for each half of the mandible arise on the bifurcations of the inferior alveolar nerve into the mental incisive branch. So you see this one is the ID nerve, inferior dental. This ID nerve or inferior alveolar nerve, then have bifurcations. We form the mental branch and incisive branch. This one is a mental branch, incisive branch. This bifurcation, which is the black color, that is the ossification center. So we have one left, one right. And then later, this one will join in the middle. We'll talk about it later. So during the 7 weeks of the IUL, bone begin to develop lateral to this metacartilage and continue until the posterior aspect is covered by bone. So between the 8th and 12th week, then this mandibular growth accelerate, then it become faster. Then as the result, mandibular length increase. So you see this one, the metacartilage. At first, this bone formation is at the bifurcation, then slowly extend posteriorly on both sides, anterior posteriorly, until they form the whole mandible. But ossification stops at the mandibular lingula, and then the remaining part of the metacartilage will form the spinomandibular ligament and the spinous process of this sphenoid. So look at these right pictures. So this metacartilage slowly will disappear. Then this bone formation happen, or mandible growth. Then this metacartilage slowly becomes smaller. Then eventually they become a styloid process, or the spinomandibular ligament, and then spinal process of the sphenoid, which is here. Then secondary accessory cartilage appear between the 10 and 14 weeks of the IUL to form the head of the condyle. So this form the body of the mandible. This metacartilage and the bifurcation, the center, left and right. This one will form the body of the mandible. Then we have this secondary accessory cartilage will appear between 10 to 14 weeks in the IUL to form the head of the condyle and a part of the coronal process. So I want you to focus on this picture. You see this picture, this peach color is a mandible, a body of the mandible, and this one light pink colors, then we all the dot, this one considered secondary cartilage. So secondary cartilage will form the condyle, and then coronal process and symphysis. We'll talk about this later. So this one by secondary cartilage. That's why we say the mandible is combination between the intramembranous and endochondral ossifications. So we have these endochondral formations, which is seen in the three areas of the mandible. The first one is a condyle, the second coronal process, then the third one is a mental process, which is at the symphysis area. So first we'll talk about condylar process. So at the 5th week of the IUL, then the area of the mesenchyma. You see, all start with this mesenchyma condensations. It's seen above the ventral part of the developing mandible. So at the 5th week, while the mandible is developing, then we start seeing this secondary cartilage will start form. So about 10 weeks, then develop a cone-shaped cartilage. And then this cone-shaped cartilage will migrate inferiorly and fuse with the mandibular ramus. You see this mandible, they cover this cartilage about 4 months. Then this cone-shaped cartilage is replaced by the bone. You see endochondral, they must have the cartilage to form the bone. Then later, this cartilage will disappear. So the cone-shaped cartilage is replaced by the bone, but it's on the upper end. It still persists or left behind, acting as a growth cartilage and articular cartilage. So you see your condyle is have a joint, which is called TMJ joint. You have a cartilage layers cover the condylar process. So these are left behind by the cartilage. So this one is just a summary. So you see on the A, there's a body of the mandible still forming. And slowly we will see this secondary cartilage, which is pink color. Then it develop initially as a separate part, mandible and the cartilage separate. Then slowly they'll come together. Then incorporate. You see this cartilage will grow inside the bone, or the bone will cover the whole cartilage. Then slowly this cartilage will disappear. Then they left only just a thin layer as a cartilage to protect the TMJ. So separation area A, or the mesenchymal condensation at 8 weeks, then fusions, all these two join together. Then at the 4 months, then after when they get birth, or when the baby born, then this cartilage will become just a little bit to cover condylar process. This one still with cartilage. Coronal process a bit different. They also have the cartilage, but this secondary accessory cartilage appear in the region of coronal process about 10 to 14 weeks of the IUL. But this cartilage become incorporated into the expanding intramembranous bone of the ramus, and it disappeared. So nothing left behind. It disappeared completely before birth. Not like the condyle. Condyle is a little bit left behind. But coronal process, everything disappeared. Only the bone left. So this one, a bit different from the condyle. Same for the symphysis or mental region. So in the mental region, 1 or 2 small cartilage appear and ossify in the 7th week of the IUL. Then it become mental ossicle. Then the ossicle become incorporate into the intramembranous growth when symphysis ossify completely. Same thing. See, the mandible, they have left and right. We have right and right part. Must be joined in the center. So this one is helped by this mental ossicle cartilage. So this one, when joined together, this cartilage also disappear. Okay. So we finished the growth or formation of this mandible. Now we go into detail. After the baby born, then what will happen to this mandible? So postnatal growth of the mandible after the baby born. Of all the facial bone, mandible undergo the largest amount of the growth postnatally. That's why we say class 2 maybe will improve with time, but class 3 most likely become more class 3 with time. So class 3 become more severe. Usually class 2 will get a bit better with time because the mandible undergo the largest amount of growth postnatally. So mandible basically is a slender, very long U-shaped bone with endochondral bone mechanism at each end, which is a condylar process. Then intramembranous growth between, which is a body of the ramus, of the mandible, as seen in the long bone. If you notice any long bone on your body, the hand and your leg, then they have a long bone, which is have a cartilage cover the long bone end. Same with the mandible. So mandible, you imagine this as a long bone, but slender, U-shape. So at the end, we have the cartilage, and in the middle, we have the bone. So at both, there are two rami of the mandible are short. The condylar development is minimum, and there's no articular eminence at the cranial fossa. So cranial fossa, it just means where the contact between the base of the skull and the TMJ. This is called cranial fossa. It's just a fossa for the attachment of the TMJ. This condyle must go into the fossa. Then in front, there's articular eminence, which is like a U shape or S shape. So when you open, this TMJ usually right forward and downward. That's how they open the jaw. So thin layers of fibrocartilage or connective tissue assist at the midline of the symphysis to separate the right and left of the body mandible. So like we discussed before, so we have the left and right mandible. So in the middle, there's this cartilage joined together when you get both. Okay. Left and right, mandibular body. And at 4 months of age, by the end of the first year, this symphyseal cartilage is replaced by bone. Then when you replace by bone, it means the bone will join together. There's no separation between the left and right mandible. That's why they say when the baby grows, actually the jaw is flexible. They are not fixed. They're not fixed. So at the first year of life, the apposition growth, which is a positive sign, deposition, is active at the alveolar border and distal and superior surface of the ramus and the condyle along with the lower border mandible and ossilateral surface. So this picture is to summarize everything. You see this mandible, they grow on the posterior, alveolar, and then the lower border of the mandible. Then we have resorptions with the anterior, and then this symphysis or below the alveolar, there's some resorption also. So that's how it happens. So you see the maxilla and mandible will go in the same direction, which is downward and forward. Again, it's by remodeling, and then remodeling and the displacement. This happen together. So after the first year of life, these changes occur. Condyle will show considerable activity, then mandible will move and grow downward and forward. Again, this word appear many times. So in the exam, they will ask you which direction the mandible and the maxilla will grow. It's the downward and forward direction. So deposition growth will occur on the posterior border of the ramus, again posterior border of the ramus, and on the alveolar process. Alveolar process has to increase in height, so the teeth can erupt. So resorption occur along the anterior border of the ramus, then lengthening of the alveolar border, and then maintaining the anterior posterior dimension of the ramus. So you see the ramus, one must be deposition, and the other side must be resorption. So it maintains the same dimensions. Then this alveolar will grow a bit longer, then the jaw will grow downward and forward. So the condyle is a special interest because it's a major site of growth. Imagine this condyle will grow, then the jaw also will grow. This is caused by the secondary displacement and the primary displacement also. So condyle cartilage is secondary cartilage, which makes an important contribution to overgrowth of the mandible, overall length of the mandible. So if the condyle go, then the jaw also will go longer and longer, go longer anteriorly and inferiorly. Coronal process standardly follow the enlarging V principle. You see this mandible is like a V shape. So if we talk about from the last lecture, this will follow the principle of enlarging V. So this V on the bottom, you see this smaller V, then slowly it become medium V, then after that become a large V. So this mandible will follow this principle. So it become a bigger V with time. So it must be a deposition on the lingua of the coronal process, and then bring about the posterior growth of movement of the V pattern. So you see the coronal process must be deposition here, and this is why the mandible will push forward and become a bigger V. Ramus, the ramus move progressively posterior by the combination of deposition and resorption. Or same time happen. Some must be resorption, then some must be deposition. So it maintain the same dimension. So one resorb, one will become deposition. So when this resorb, they give you more space for the third molar to come out. So resorption occurs on the anterior part of the ramus, while bone deposition occurs in the posterior region. So anterior region, we have a resorption, then posterior region, we have a deposition. So because of the resorption at the anterior border of the ramus, so additional space is available to accommodate the erupting permanent molar. So you have second molar, then we have third molar, which is waiting to come out. That's why your mandible must grow a bit longer with time. So how it happens is by resorption at the anterior region, and then deposition at the posterior region. So the jaw becomes longer. They give you more space for the eruption of the second and the third molar eventually. So the body of the mandible grows in 3 dimensions: anterior, posterior, then laterally and vertically. So lengthen due to the resorption and deposition of the mandible, then whiten due to the growth of the alveolar process and erupting teeth, then flare, which is a V, enlarging V principle. So angle of the mandible, this angle of the mandible, showing the picture in the middle, this corner is called angle of the mandible. From the lingual aspect, then we have the resorption occur in the posterior inferior aspect. Then we have deposition occur in the anterior superior region. And on the buccal side, we have resorption occur in the anterior superior part here. Then we have the deposition happen in the posterior superior part here. So this result in flaring of the angle of the mandible as the age advances. When you get older, then become bigger V. Alveolar process, it develops in response to the presence of the tuber. So if you notice, this alveolar process will coexist with the teeth. If there's no teeth or no tooth, then the bone will resorb. So when there's a teeth, there's an alveolar process. Then when the tooth is gone or the teeth is gone after extracted, then the alveolar process will become resorbed. So as the teeth develop and increase in height by the bone deposition at the margin, and add to the height and thickness of the body of the mandible, and is particularly manifested as the ledge extending lingual to the ramus accommodate the third molar. See this one is the ledge to accommodate the third molar. But if you ever give this ID block, inferior dental nerve block, inferior alveolar nerve block, so you notice this one is mandibular foramen, is where the insertion of the ID nerve. This maintain constant position midway. Midway means half between the anterior and posterior border of the ramus. So this is the anterior, and this is posterior ramus, border of the ramus. So midpoint is always where the insertion of the ID nerve. So when you give injection, you always aim for this area where you can numb the nerve or the mandible. So that's where you should deposit all your LA solution. So the chin, so in infant, when you're infant baby, the chin is underdeveloped. You see, look at all baby, the chin is a bit underdeveloped. They always present with a class 2 face or class 2 skeletal pattern because the chin is underdeveloped. So it's always get a double chin. Babies always have double chin. It's very common because the chin is not developed yet. So as the age advances, the growth of the chin becomes significant. You see, when they grow older, the chin will become sharp compared to baby. So the male are seen to have more prominent chin compared to the female. The prominent is accentuated by the bone resorption at the alveolar region below it and creating a concavity. You see there's an alveolar process. Just beneath this alveolar process, there's a resorption. When the resorption happens, then it creates a concavity. It's like the chin will stick out a little bit. So when you get older, then the chin will become more chinny. That's common. Okay, I think with that we cover all the topic, the growth of the maxilla and mandible. So maybe we just summarize everything. So maxilla, we know maxilla, their growth is by intramembranous, and they usually happen by the remodeling and displacement. So remodeling, we have remodeling, we have the resorption and deposition, and displacement, we have the primary and secondary. And then this one is just a prenatal growth. You just have to know these pictures. You can draw these pictures very good. This one I just show that all the processes will come together and we have a mouth in the middle. Then later we'll form three parts of the face, upper, middle, and lower. And we have to know the primary palate and secondary palate. And this, if fail to fuse together, then we will form the cleft. It's very important. So if a cleft happen, then the life basically is traumatized because they will go through a lot of complicated treatment. So this primary palate must be fused together with the secondary palate, and on top is the nasal septum. All have to join together. They form a beautiful nose and your mouth. Okay, we have cleft. And the growth of the maxilla is a downward and forward direction. Then usually go in the suture, this side remodeling and displacement again. Then we talk about detail how this maxilla will grow, and the palate also, anterior nasal spine. Then we go to mandible. So mandible usually formed by intramembranous on the body of the mandible. Then we have three parts, which is by the endochondral, which is condyle, coronal process, and then the symphysis. This three part is by the endochondral, which is by the secondary cartilage. Then slowly this cartilage will disappear, which is the coronal process will disappear, symphysis will disappear, and then this condylar process will left behind by a thin layers on the TMJ. Okay, then we talk about detail, what happened after the baby born, what will happen to the mandible. Then we talk about this ramus, how it grows, how it accommodates the second molar and third molar. Then the chin, how it grows, become longer, ramus, body mandible. And then third molar, and we talk about the foramen, then we talk about the chin. Okay, I think with that, I cover all the topic, which is the maxilla and mandibular growth. Any questions?
So far it's clear, Doctor.
Okay. No questions. This is a very complicated topic. I'm surprised, no questions. It's okay. Are you coming to final year or you just started your fourth year?
Just started.
Okay, so you mean previously your third year. Have you seen any patient yet?
Not yet, Doctor.
Not yet, Doctor.
Not yet. Okay, so you're going to start the clinical year soon. Yeah?
Yes.
Okay. All right. I think when you start the clinical year or you start seeing patient, then you can appreciate the growth more. It's okay. Just keep in mind this lecture is complicated. It's complicated. So sometimes if you don't understand, it's okay. So once you do more revisions or we go to more complicated lectures, which is jaw modifications or growth modification, class 2, class 3, and we are talking about the extraoral appliance and intraoral appliance. Each we can talk about how we're going to change the growth according to the patient age. Then I think they are more interesting. Any questions? If not, I think I will end this lecture. Just before I forget, to sign your attendance before you go off. Okay, no question, then I'll see you soon. I think the next topic with me is class 1 malocclusion. So we are talking about classifications, incisal, molars, and how we classify it as a class 1, class 2, class 3 accordingly. Yeah? Any questions? If no, then I will end this lecture. Yeah, I'll see you soon.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Bye.
Thank you.